This conference will now be recorded.
మటన్ రాలేదా మెడిసిన్ ఇప్పుడు వాటర్ Good morning to everyone. So today's topic for discussion is dysphagia. So dysphagia is difficulty in swallowing. So it refers to the problems with the transfer of the food or liquid from the mouth to the hypopharynx or through the esophagus. So this is the physiology of the swallowing. So it consists of three stages: a voluntary stage, pharyngeal stage, and esophageal stage. A voluntary stage which initiates the swallowing process, and pharyngeal stage it is involuntary, constitute passage of food through pharynx into the esophagus. Esophageal stage it is also involuntary. We transport the food from pharynx to the stomach. So these are the different actions and different stages of the swallowing. So initially there will be elevation of the tongue and the posterior movement of the tongue, followed by elevation of the tongue and elevation of the soft palate and elevation of hyoid, and followed by elevation of the larynx and tilting of the epiglottis and closure of the epiglottis, which will prevent the food entering into airway. So this is the basic mechanism in the neurological structure which helps in the swallowing process. So when there is a peripheral stimuli in oropharynx and larynx and esophagus, the sensory neurons of the 5th, 7th, and 9th and 10th cranial nerves will get stimulated, and they will transmit the impulses to cortical and subcortical structures. So from there, the brainstem swallowing centers will be activated. There are two brainstem swallowing centers. One is dorsal swallowing group, another one is ventral swallowing group, and this gets activated after sensory stimuli and get sensory stimuli from esophagus and throat will enter after entering into the cortex and subcortical structures, followed by activation of these brainstem sensors and brainstem centers. The motor nuclei will activate it. Motor nuclei means one is from oropharyngeal and another one is from esophagus. So motor nucleus of oropharynx include trigeminal nerve, facial nerve, and ambiguous nucleus and hypoglossal nerve, and cervical nerve from C1 to C2. So these are the oropharyngeal motor nuclei, and the esophagus means dorsal motor nucleus of vagus nerve is the motor nuclei for esophageal structure. So and the motor neurons includes for oropharyngeal structure, the motor neurons are 5th, 7th, and 9th, 10th, 11th cranial nerves, and for esophagus the 10th cranial nerve. So after activation of these motor neurons, so this phase will activated. Once motor neurons of the oropharyngeal system get activated, the oropharyngeal swallowing process will be get done. After activation of the 10th cranial nerve, primary peristalsis will start. So etiology of the dysphagia. So it can be subclassified by both location and circumstances in which it occurs. So based on location, it can be either oropharyngeal or esophageal dysphagia. Based on circumstances, it can be structural or propulsive or motor dysphagia. So structural dysphagia means it is caused by an oversized bolus or a narrow lumen. So structural means when there is a narrowing of the lumen or when the passage is obstructed by oversized bolus. Whereas propulsive or motor dysphagia means it is caused due to abnormalities of peristalsis or impaired sphincter relaxation after swallowing. So structural means when there is a large foreign body or bolus obstructing the lumen or narrowing of the lumen. Propulsive or motor means when there is a defect in peristalsis or impaired sphincter relaxation. So these are the types according to circumstances. According to location, it is oropharyngeal or esophageal dysphagia. Oropharyngeal dysphagia. So arises from the disease of the pharynx, upper esophageal sphincter, upper esophagus, composed of sided muscles. So it is associated with the poor bolus formation and control characteristics. Characteristic signs are so when there is when we suspect oropharyngeal dysphagia, these are the characteristic features. So difficulty in initiating the swallowing and drooling will be present, and regurgitation into the nasal cavity, aspiration may be present, hoarseness of voice or cranial dysfunction may be associated with the oropharyngeal dysphagia. So when there is oropharyngeal dysphagia is present, so there will be difficulty in initiating the swallowing will be there, and regurgitation of the food, drooling from the mouth and drooling of the saliva from the mouth will be present, aspiration will be present, and oropharyngeal dysphagia is associated with the hoarseness and other cranial dysfunction. So esophageal dysphagia, it mostly arises from the lower part of the esophagus and lower esophageal sphincter and cardia of the stomach. It mostly involves the smooth muscles innervated by a myenteric nerve plexus. So dorsal motor nuclei of the vagus triggers the peristalsis via the uh, via medullary preganglionic neurons. Solid food dysphagia occurs when the lumen is narrowed less than 13 mm, but can also occur with large diameters in the setting of purely masticated food or motor dysfunction. So circumferential lesions are more likely to cause dysphagia than lesions that involve only partial circumference of the esophagus. So when there is a total circumference involves, then dysphagia more common than partially circumferential involvement of the esophagus. So this is the flow chart according to the symptoms and clinical features. So when you suspect the dysphagia, if there is a difficulty in transferring the food through the mouth, so if you find these type of features like immediate difficulty while swallowing, or repetitive swallowing may be necessary, or repetitive coughing or choking or nasal regurgitation is present, so suspect oropharyngeal dysphagia. Oropharyngeal dysphagia may be mechanical or neurogenic or neuromuscular. So if there is a food sticking after a swallow, so the sensation of the food sticking is present in neck, then suspect oropharyngeal, or if these features are present like delayed onset or menors may relieve the menors of repeated menors like repeated swallowing, or may painful swallowing is present, suspect the esophageal cause, or if the food sticking is present in retrosternal area. So if these features are present, suspect esophageal cause of the dysphagia. So the esophageal dysphagia is present for solid foods only, so then it is a mechanical cause. When esophageal dysphagia is present for both solids and liquids, so it is neurogenic or neuromuscular dysphagia. So approach to the patient. So history. So when we take a history, these are the key elements to find out. So one is localization of the dysphagia, circumstances in which dysphagia is experienced, and other symptoms associated with it, and progression of the dysphagia. So localization. So when the sticking or foreign body sensation present in suprasternal area, so suspect oropharyngeal dysphagia, or an esophageal etiology. Distal esophagus is referred as proximal 30%. So chest, when the discomfort is present in chest, so suspect esophageal dysphagia. So oropharyngeal dysphagia, when there is an Intermittent dysphagia with solid food means structural abnormality will be there. So constant dysphagia, if there is a constant dysphagia with both liquids and solids means there is a motor abnormality. So progressive over weeks to months means, so there will be pathology will be neoplasia. So, if the swallowing is episodic, if the dysphagia is episodic for solids or unchanged over years means benign diseases like Sjatski's ring or eosinophilic esophagitis. So food impaction even with ingestion of liquid structural uh, food impaction even with ingestion of liquid means we have to suspect structural dysphagia. History of heartburn preceding dysphagia. So suspect peptic structure, esophageal adenocarcinoma. So AIDS esophagus due to opportunistic infections like Candida, herpes, CMV, Kaposi sarcoma, and lymphoma. So history of atopy like eosinophilic esophagitis. So this is the simplifying table according to clinical features and uh, uh, most probably etiology. So when there is difficulty in initiating the swallowing, suspect oropharyngeal dysfunction. When there is a repetitive swallowing for bolus or liquid, bolus of the food or liquid, so suspect oropharyngeal dysfunction. So when there is retrosternal hanging up or sticking sensation is there, suspect esophageal dysfunction. So when there is difficulty with solids and but not for liquids, so suspect mechanical obstruction. So when there is difficulty with both solids and liquids, so suspect esophageal dysmotility. So regurgitation of undigested food means suspicion of juncus diverticulum, and halitosis is associated with the juncus diverticulum. So physical examination, look for the signs of bulbar and pseudobulbar palsy. So when there is a bulbar and pseudobulbar palsy, the neck muscles will be paralyzed and the pharyngeal muscles will be paralyzed. So when there is a bulbar and pseudobulbar palsy, these may be associated with the dysarthria, dysphonia, ptosis, tongue atrophy, hypertrophy of the jaw jerk, hyperactivity of the jaw jerk, and look for evidence of generalized neuromuscular disease. So neck, look for when we examine the patient, when we examine the neck, look for thyromegaly, which is obstructing the food pathway. Look for mouth and pharynx lesions, and look for missing dentition. So when there is a missing dentition, there will be interference with the food mastication and exacerbation of the existing dysphagia. Physical examination is less helpful in esophageal dysphagia. Exception is skin diseases like scleroderma, subcutaneous disease such as pemphigoid, lichen planus, and epidermolysis bullosa may be associated with the dysphagia. So these skin conditions like scleroderma, lichen planus, epidermolysis bullosa will associated with the dysphagia, esophageal dysphagia. So this is the flowchart depicting different clinical features and um, ecological factors for dysphagia. So when the dysphagia is categorized into oropharyngeal and esophageal dysphagia. So oropharyngeal dysphagia, suspect the oropharyngeal dysphagia when there is a dysphagia localized to neck, nasal regurgitation or aspiration are associated with the ENT symptoms. So suspect oropharyngeal dysphagia. So oropharyngeal dysphagia can be structural. So structural are propulsive. Propulsive means motor. So structural dysphagia causes includes juncus diverticulum, neoplasm, cervical web. These are the most common causes for structural oropharyngeal dysphagia. So another causes include cricopharyngeal bar, osteophyte formation, congenital abnormalities of the oropharynx, post head and neck surgery, radiation, corrosive injury, or infections. These are the causes for structural oropharyngeal dysphagia. So in this, juncus diverticulum and neoplasm, cervical web are the most common causes. So, propulsive or motor causes of oropharyngeal dysphagia can be further divided into neurogenic or myogenic. So, neurogenic causes include cerebrovascular CVA, cerebrovascular accident, Parkinson's or amyotrophic lateral sclerosis. So, like motor neuron disease, brainstem tumors, Guillain-Barré syndrome, Huntington's chorea, polio, or multiple sclerosis. All these can cause neurogenic causes of oropharyngeal dysphagia. And myogenic causes include myasthenia gravis, polymyositis, mixed connective disorders, oculopharyngeal muscular dystrophy, and paraneoplastic syndrome, sarcoidosis. So these are the muscular myogenic causes of oropharyngeal dysphagia. So when it comes to esophageal dysphagia, suspect esophageal dysphagia when there is a dysphagia localized to chest or neck or the food impaction. Suspect the esophageal dysphagia. So when there is a dysphagia for both solid and liquid, so that must be propulsive or motor cause of esophageal dysphagia. So when there is a dysphagia for both solids and liquids, suspect propulsive cause or motor cause of dysphagia. So these propulsive causes include achalasia, diffuse esophageal spasm, or scleroderma. GERD may be sometimes associated with a weak peristalsis. So solid dysphagia only dysphagia with only solids in place. Structural causes of esophageal dysphagia. These structural causes includes further divides into characteristic features. When there is a intermittent dysphagia, suspects Schachke's ring or esophageal web. So when the structural dysphagia progressive, so suspect neoplasm. So when the structural dysphagia is variable, so it must be it may be peptic stricture or eosinophilic esophagitis. Sometimes hiatal hernia or extrinsic compression of esophagus or surgical stenosis or radiation esophagus may be present with the structural esophageal dysphagia. So odynophagia. So odynophagia means painful swallowing. So pill esophagitis or infectious esophagitis, plastic injury, chemotherapy, sclerotherapy, Crohn's disease or Behçet syndrome. All this can be present with the odynophagia means difficulty in swallowing with pain. So dysphagia testing. So these are the different testing methods for different types of dysphagia. So if oral phase of dysfunction is suspected, so these screening test includes clinical examination, cervical auscultation, and 3 ounce water swallow test. The primary test include modified barium swallow. So when we suspect the oral pathology, so primary test is modified barium swallow. If pharyngeal phase of dysfunction is suspected, so same clinical examination, water swallow, timed swallowing, and primary test is modified barium swallow. So this is the modified barium swallow for pharyngeal pathology. Modified barium swallow is for both oral phase and pharyngeal phase, and complementary test for pharyngeal phase is pharyngeal video endoscopy, pharyngeal manometry, electromyography, and video fluorometry. So video manofluorometry. These are the complementary tests for diagnosing a pharyngeal pathology. If the esophageal dysfunction is suspected, so video fluoroscopy and endoscopy are the primary tests, and complementary tests include esophageal manometry. So primary tests include video fluoroscopy or endoscopy. Complementary test of esophageal manometry for esophageal pathology. So these are the different tests for diagnosing the dysphagia. So this is the barium swallow image for different pathologies. So this is the bud beak sign for achalasia. So this is the bud beak sign. So this is the sigmoid esophagus in achalasia cardia. So this is the S-shaped sigmoid esophagus. So this is the corkscrew esophagus. So nutcracker esophagus. So this is called as diffuse esophageal spasms. So irregular defect. So this is the irregular filling defect when we do barium swallow in carcinoma esophagus. So when we look into endoscopy, so this is the normal esophageal mucosa. So this is the inflamed reddish color esophageal mucosa depicting esophagitis. So this is the normal esophageal lumen. So this is the esophageal diverticulum. So one of the cause for difficulty in swallowing. So this is the Schachke's ring. So normal lumen may be widened than this. So this is the normal esophageal lumen. So whereas this is the Schachke's ring. So this is a manometer study depicting the normal peristalsis and achalasia cardia. So this is the peristaltic waves, and there is no peristaltic waves in achalasia. So the complications due to dysphagia means so inadequate nutrition, dehydration, and recurrent upper respiratory tract infections, fan aspiration, and consequent pneumonia may be present, and sometimes asphyxia may be present due to dysphagia. So grades of dysphagia. So grade 1 means complaints only dysphagia for no, complaints of dysphagia, but eating is normal in grade 1. So still there is a complaints of dysphagia, but eating is normal in grade 1. Whereas it comes to grade 2, so requires liquid with the meals. When taking the solid foods, it requires the liquids. It is grade 2. Grade 3 means able to take semi-solid but unable to take any solids. In grade 3, complete difficulty in swallowing for solids, but he is able to take semi-solids. In grade 4, he is able to swallow liquids only. So grade 5 unable to swallow liquids but able to swallow saliva. In grade 5 is unable to swallow liquids also, but able to swallow his own saliva. In grade 6, complete difficulty in swallowing and unable to swallow his saliva also. So treatment for dysphagia, lifestyle modifications like avoidance of respirating factors like fatty food, alcohol, and caffeine, oral hygiene, elevation of head of the bed, smoking of cessation, and weight reduction. These are the lifestyle modifications for dysphagia. So treatment for oropharyngeal dysphagia due to neurogenic disorders. Postures are maneuvers to reduce the pharyngeal residue and enhance the airway protection. So altering consistency of food and liquids reduce the aspiration. So dysphagia from CVA usually improves within first few weeks. So cortical dysphagia improves greater than brainstem dysphagia. Severe and persistent cases go for percutaneous enteral feeding and enteral feeding. So thermal tactile stimulation is useful in neurogenic disorders. So posture and maneuvers, so which will improve the esophageal motility. So altering the consistency of the food and CVA, persistent dysphagia is present. Go for percutaneous enteral feeding or enteral feeding, thermal tactile stimulation. These are the modalities for oropharyngeal dysphagia. So drug therapy for esophageal dysphagia. So if there is a reflux esophagitis, use H2 blockers or proton pump inhibitors. Antacids, dampirid and metoclopramide may be helpful in reflux esophagitis. So motility disorders, for motility disorders, use nitrates, calcium channel blockers, and Botox injection. The motility disorders, achalasia cardia, can be treated with nitrates and calcium channel blockers. So caustic injuries, if you suspect caustic injuries, add steroids. So vinegar, lemon, orange juices for alkali injury. So when there is alkali injury, so acid containing foods like vinegar, lemon, and orange juice can be given. So when there is a acid injury to the esophagus, add milk, egg white, and antacids for the food. So dilatation. So indications for dilatation is strictures, Schwarzkopf's ring, achalasia, and anastomotic stenosis. So these are the indications for dilatation of the esophagus. Surgeries like cricomyotomy, fundoplication, and hernia crural repair, esophageal resection, and anastomosis. So cricomyotomy can be done for motility disorders and neuronal dysphagia. Fundoplication can be done for reflex esophagitis. Hernial repair for hiatal hernia, esophageal resection, and anastomosis for malignancy and long-standing achalasia and caustic injuries. So esophageal resection can be done for these pathologies like malignancy, long-standing achalasia, caustic injuries. So, so this is the dysphagia. Thank you.